Thank you very much to both Mandy and Karen for some excellent presentation. I think Mandy's discussion on the umbilical cords is really interesting. It's starting to focus us much more, and it's been, I think, a long time in coming. We probably should have done this a lot longer. We've been thinking about cords for ages. But first of all, does anybody have any questions from the audience at all to either of our two speakers? Charlie.
That was really interesting, Mandy. On the cord torsions, I guess I've always expected that if it's pathologic, you would see swelling in the cord. Did you look at that, or did I just miss it?
So are you thinking about like urachal dilations, or are you thinking about wider swelling across the cord?
Just as you twist it, eventually you get venous congestion and the cord swells at local areas.
So we haven't looked all the way along the cord. We looked at the widest point. When I said the diameter of the cord, where it was thicker, you do get dilations, yes, but whether they're sort of succulated, are you thinking about whether they're sort of more succulated across? There is some changes in time, but we haven't quantified those across the amniotic cord, and that's what we need to work out. What was interesting is we did mark, the measures I talked about were at a very specific location within the amniotic cord, so they weren't targeting a particular swelling across the cord.
So was the increased in diameter, was it due to then increased diameter of the vessels, or was it due to edema? Like, could you differentiate edema within the tissues?
We think it's both. What the evidence for the edema is, you've got some sort of splitting along the cord as well, which is suggestive of edema. So we're trying to quantify that. We're interested also in the sort of collagen content, so the constituents of the cord, and there are ways that we can go and actually quantify the different types of collagen. But edema, there was evidence through this splitting along the cord. We had debates about whether they split this way or this way as to whether that meant it was edema or stretching.
And was there edema in the choriolentois too? Like, did that look?
We had more reddening in the choriolentois rather than edema. Yeah. So more congestion rather than straight edema.
I think this data is really, really interesting because, of course, we've looked at, and certainly in the UK, and I'll maybe ask Karen in a minute, why she thinks they see so much less umbilical cord torsion in the USA. But from our point of view, this would be our biggest cause, and so probably 40% of our losses that we would see during pregnancy would be from umbilical cord torsion as a proportion of the abortions we see. Now, as Mandy showed really well, it's still a very small number of the total number of mares, and for a condition where there's no real premonitory sign at all, so we find our aborted fetus the next morning, the mare is fine the day before, we don't see anything associated with it. We're now in a situation maybe where we can start to find out from this data, we're starting to see that the time period where we maybe want to study these mares, because if you're thinking, well, should we look at mares on a regular basis? We still don't know whether the torsions occur very quickly, if they're acute, or whether they're more chronic. We start to think maybe they are more chronic. So if they are acute, obviously the signs of them being a problem could be very short, and we could scan a mare one day and she's fine, and the next day she aborts. So that's maybe not very helpful. But we're getting down to this stage now. Now, one of the biggest problems, of course, is that looking for cords rectally or transabdominally is quite hard. But the easier periods are as you get further towards the earlier parts of pregnancy. So you can do this a little bit more reliably. And notwithstanding the fact that we're going to have to look at a large number of mares to find evidence of a small number of cord torsions proportion, because we're looking at a normal group. We don't know they're going to have a cord torsion. We can't focus in on those cord torsions that much. I think this is still giving us some idea of which mares we need to target. You know, the information on it that this three consecutive pregnancies is more of a group you could target. So I think this is getting much more interesting. Do you think the genetics of cord will give us an idea? Because obviously a lot of these things we're talking about with scanning mares during pregnancy are quite time consuming. We maybe want to do mares at the wrong time of the year. These mares will be out at grass by and large during the summer and into the autumn. They're not very keen on coming in to be scanned. They can be very excited. You can't really sedate them if you're trying to look at the vascular dynamics of the cord. If you sedate them also, the pregnancy drops out of sight, which is hard to see rectally, maybe better transabdominally. So there's a lot of technical problems with it too. So the genetics of it may be interesting. If, again, we could focus in on a group of mares to look at rather than trying to do all our mares.
That's why we don't have them in America.
But you have placentitis, you see, you're looking for
Well, it might be
placentitis
genetics too. Let's just go with genetics on everything now. But I mean, I think that genetics has a big play in it, and I'd be very interested to see what you guys come up with. I think also what some people have suggested, and I don't know quite how I feel about it, but we get accused a lot of using altrinogest, and I don't know, I guess there's a theory behind that basically our fetuses don't move as much because they're quieter because of the altrinogest. But I think you could go back and look at the umbilical cord torsions that have been diagnosed and then potentially go see if they've been on altrinogest, and that might be able to answer that question. I don't think we have enough to say one way or the other at this point in time. I will say, though, that your work is absolutely intriguing, and it gets my brain going a little bit too much. But I think that we do some fetal sexing in a window between 115, 125 days transrectally, and it's pretty easy to see the umbilicus at that stage. So if you had normal values for that stage of gestation, maybe you could identify enlargement at that stage and then potentially follow those, or then see if those mares are at higher risk or do abort from umbilical cord torsion. But, I guess the question would be, is at what stage of gestational process, is it really 115, 120 days, or is it really 180 days? And you'd have to, like you said, Andrew, do a lot of serial ultrasounds, both transrectally and transabdominally, to find. And I find it very difficult to find it transabdominally. Even fetal sexing 160 days, it's sometimes hard to follow the umbilicus more than just where it comes into the body. At least for me it is.
Karen, I think, I don't know how many, whether it's mainly vets now or people who are working on studs, but would you comment a little bit more about the use of routine treatment, so the strategic monthly treatment, which I think my sort of personal view would be a little bit that we're somewhat influenced by the American, not fixation with placentitis, but the fact that it occurs so much, that there's a little bit of an idea, and people will often say to me, do we need to put this mare on because she's lost a pregnancy? Do we need to put her on to monthly antibiotics for a week, every month for the rest of her pregnancy? Is that still a popular regime in the US?
You just open Pandora's box, because that's kind of one of my pet peeves, to be honest. I think that I am very much against doing that blanketly. I think we are not being good stewards of antimicrobial resistance. I think that with what we have now with regards to ultrasound, I would much rather be able to ultrasound those mares monthly to try and identify a reason to put them on treatment. And I think that with potentially the different tests that may become available, that might be a better way to then dictate what treatment our mares get. Having said that, am I going to tell a farm manager who has a $5 million mare not to do it? Probably not, to be honest, because if anything happens, then it's not a good situation. So I think you have to weigh the pros and cons of each situation, and I think you have to follow them as practically as you can for the situation that you're in. Did I answer that diplomatically?
Question from the audience.
It's the regumate debate in the treatment and or prevention. And speaking to Jane Axon, she was quoting Joan Carrick, who did research, and when you start wanting to affect the cervix in terms of patency, so to really crank down the cervix, she was talking about a quadruple dose before you're doing anything at all. So that's been the regimen that we've been using. So with clinical cases of ascending placentitis, the dose is seriously high, like 88 milligrams per hour BID. Any comments on that? Reference to using Regumate, but at what dose?
Karen.
Yeah, so I have not seen any literature out there that has had controls or studies on dosage. I will say that the only studies on dosage have been the double dose Regumate for mares that have had colic or inflammation associated, and so they found that they have a better outcome with double dose. I don't think that anybody has controlled studies in which they look at diameter and then put them on a dose and look at diameter again. I guess I have enough of a quandary in my mind of whether or not using Regumate or not is beneficial, so I would hesitate to do that high a dose with the caveat that we're not sure what it's doing to the immune system to begin with. So if you're already on the borderline is should we use it or should we not because of the immune effects, I guess going to that extreme would concern me even more. So in my mind, the question is always, do I put them on Regumate? And then if I do I put them on regular dose or double the dose? But I have never quadrupled the dose. And most of the time, I will put them just on the regular dose of Altrinagest. I don't know if anybody has.
Yeah,
It's an interesting question, isn't it? I can't comment clinically, but if you also often think about the mechanism, so there is data on the immune responses to Regumate being modulated, but also I think about the progesterone receptor, because there'll be a saturation point anyway, and so whether you're throwing away money when you meet that. And there's also some work done in earlier pregnancy, I can't comment on late, where the progesterone receptor gets down-regulated by progesterone. So it's
Right.
sort of a thinking about, where you meet that in the middle, I guess.
Any more questions?
So maybe that's a study you want to do, Benny.
I think the one thing I think to say about the umbilical cord, again, people may say, well, okay, you've diagnosed your umbilical cord, are you going to be able to, the potential for a torsion, are you going to be able to do anything about it? Well, there's a possibility maybe using aspirin in those situations, but the ischemic necrosis we see, so that is an inflammation of the placenta associated with often with long cordedness and with a lack of blood flow within the placenta. That would seem an area that could well respond to aspirin therapy. So at least in those cases, you may have a chance of saving those pregnancies or letting those pregnancies progress to full term with more viable placenta so that the foal is a more viable individual. So I think even if we're maybe a long way from being able to do anything to stop cord torsions, there's that, again, proportion of cord-related disease that we may be able to do something about. So I think looking at this from a diagnostic point of view is still really interesting.
I'm just thinking, Andrew, too, about your comments about scanning and how many we have to do. If we thought of mares that had 3 previous pregnancies were 10 times more likely to have an excessively long cord, we could essentially target just mares with 3 previous pregnancies and potentially those have had a previous abortion, and we might be able to get our numbers more
Do you think
manageable.
that the 3 pregnancies stems from the development of the placenta, right? Because maiden mares, their microvilli are not as developed, and it takes a couple of 2 to 3 pregnancies, well, you'd know better than I, for those microvilli to, in fact, develop to their full potential. And so maybe it's more, so that's maybe a reason why.
Yeah, absolutely. We tried to find data on this, actually, about measuring uterine volume. So when we saw this, we thought, has anyone actually measured that? We can't actually find anyone that's truly measured it. Indirectly, as you say, it's to do with placenta size. So we know with multiparous mares, their placentas are bigger, so we assume the uterus is bigger. But it'd be quite nice if we could find a way to measure the size of the...
Is it bigger? Is the
uterus.
vascularity more developed? And, you know, yeah, I mean, the older mares, they have baggy, saggy uteruses, but their placentas aren't necessarily bigger or better. So I think it's more branching of the vessel.
It's surface area, I guess.
Yeah, I guess of the blood flow, then maybe,
Yeah.
I mean, I've sort of always thought of it as much for why we see the cord torsions in this mid-pregnancy period is as much to do with the fact that the fetus is still relatively small and has the room to twist around, whereas as you go much further in pregnancy, there's much less opportunity for the fetus to actually rotate. So once you get beyond 7 or 8 months, the fetus will be in anterior presentation, whereas prior to that, it will be in anterior or posterior presentation. There's so much more room, if you like. So it's a case of being a sort of a smaller creature in a big swimming pool rather than a big creature in a bath sort of thing. So
although it's interesting because in America, I'd say that I've always, just thinking about it, I always think of it as a late-term problem, abortion versus an earlier one. Not that we see that much, but it seems to be kind of the, in just going off my clinical exposures, is more like 8 months, you know, which would be interesting to go back and look at ours versus yours.
Charlie.
I think on your chart, Mandy, did you say the thickness of the cord was 11 centimeters and those were affected? That's big.
Yep, they were.
So that would seem to be something you might be able to see ultrasonographically if you can get anywhere close to the cord, right?
That's what we're hoping, that we could...
And then also, did you see any changes in the fetuses?
the fetal...
Because I think the fetuses were smaller, right?
So we wondered if we could see growth restriction because of this subacute to chronic condition. That was our hypothesis. When we corrected for gestation age, there was no difference in fetal weight or crown rump length, which was a bit disappointing because we thought that's probably what we might see from this chronic condition. But no, we weren't able to see that. Jessica's gone back to look at the fetal condition, so we haven't actually quantified those other fetal parameters, so she's looking through pathology
what about
reports
the fetal
to
bladder?
do that. Yeah, because we wondered that, whether ruptured bladders actually were associated with this. We didn't look, but it'd be really interesting to see if ruptured bladders have had this
size of the bladder
to chronic. Yeah, we haven't measured that, but it was definitely worth looking. Yeah, good.
Any more questions? Maybe I could just finish up by just asking one final question. Stallion lymphocyte immunization for early pregnancy loss used to be quite popular. Twink Allen was a key instigator in it. What's the current thinking? What's the immunological thinking, as you're an expert immunologist on that? I'm not sure. I don't know whether if any of the stallion studs are here. Possibly whether stallions are being asked to have their blood taken for immunisation. Is that still going on? No.
Oh, good.
So.
So
I was like, I didn't know that was still happening.
So there's not a lot of data, like if you look at the strict data on that, there's not any data to support it. And what's quite interesting though in women, so there's no data in the horse. There was some preliminary data that looked really promising, but then the follow-up data showed no effect. They've done sort of similar processes in women that have recurrent pregnancy loss, and they just did a massive sort of meta-analysis of that group, so if we can draw from that. What was interesting is they only found an effect when women had, I think it was either 4 or 5 pregnancy losses in a row, and then you use this treatment. So it was a very specific subpopulation that it was effective, but if you have 1, 2, 3 pregnancy losses, there was no effect. Horses, I'm not a big fan of that because I don't think we have any data to support the use of it.